Hello everyone, my name is Amanda Davis, and today we're going to talk about a case study involving an adolescent with seizure disorder. So let's begin by talking about what seizure disorder, also known as epilepsy, really is. Epilepsy is a group of disorders affecting electrical activity in the brain that causes seizures, and around 50 million people worldwide have some form of this condition. Seizures are characterized by recurrent, unprovoked, abnormal bursts of electrical brain activity. There are different classifications and kinds of seizures. The two main categories of seizures are referred to as generalized onset and partial or focal onset. Generalized onset seizures affect both sides of the brain, and a few examples of these would include tonic-clonic, absence, and atonic seizures. And partial onset seizures only affect one part of the brain and include focal onset aware or simple seizures and focal onset impaired awareness or complex seizures. Some general symptoms of seizures include loss of awareness, confusion, convulsions, and body stiffness during an episode. With epilepsy, there are some considerations such as how to manage a seizure in the event that one occurs, drug interactions, side effects such as phenytoin-induced gingival hyperplasia, and we also need to know how possible triggers that could initiate a seizure, such as the bright dental light or even stress from dental anxiety. It is also important to consider how local anesthesia can lower the seizure threshold, therefore increasing the likelihood of an event. In the case that a seizure does occur in the dental chair, it is important that we as providers know how to manage it. It is important to have a detailed medical history and to move the patient to the floor if possible to avoid them falling out of the chair. It is crucial that the patient's head is supported and that they are turned onto their side for the duration of the episode to avoid aspirating. The oral cavity also needs to be cleared for this same reason. The time the seizure begins until it ends needs to be recorded, and if the seizure exceeds 5 minutes, 911 should be called. Never place anything in the mouth of a patient experiencing an episode. So now let's meet Sally. Sally is a 14-year-old girl who is a freshman in high school. Sally just moved to the area and she is a new patient at our office today. She enjoys making YouTube videos with her friends, feeding ducks at the park, and volunteering at the local animal shelter. She lives with her father and her grandmother, who are her legal guardians, and she has a great support system of family and friends. Sally has a good socioeconomic status and is on her father's health and dental insurance. Down the road, Sally is hoping to convince her father to let her get a service dog for her condition. So looking at Sally's medical history, we can see that she has epilepsy. With her epilepsy, she experiences generalized tonic-clonic seizures. Going down the list, I found that she only flossed 4 times a week, and bleeding occurs when she does. She also only occasionally uses mouth rinse. She has had a lingual retainer since she got her braces off in 2023. She's experiencing depression and photosensitivity. She sees a general practitioner and a neurologist for her condition, and otherwise is in perfect health. Her last dental x-rays were a year ago today, and she is taking phenytoin, also known as Dilantin, for her epilepsy. Prior to taking this medication, she would have an episode 1 to 2 times a month. Sally's last seizure was around 1 month ago when she had forgotten to take her medication for a day, and the seizure lasted around 3 minutes, which is normal time for a tonic-clonic seizure. Sally has never had an episode that exceeded 5 minutes. The main reason Sally is here today is because she is here to get her 6-month cleaning and to get established at a new office because she's new to the area. She also has a chip on number 8 from a previous seizure. Sally also mentioned that her gums look irritated and swollen, which could indicate gingival hyperplasia. Looking more into Sally's condition, I learned that she got her official diagnosis 3 months ago, and she experiences generalized tonic-clonic seizures, or GTCS for short. Prior to medication, these episodes occurred 1 to 2 times a month and are preceded by a visual aura, and she's currently managing her symptoms with Dilantin. Tonic-clonic seizures are formerly known as grand mal seizures and involve a full loss of consciousness and full body convulsions. The tonic phase comes first. This is the initial muscle stiffening and loss of consciousness, and the person may let out a loud cry or groan. This initial phase lasts about 10 to 20 seconds. The second phase of the episode is the clonic phase. This is the convulsive phase where the muscles begin to rhythmically contract and relax. This typically lasts around 1 to 2 minutes. The person can be very fatigued and sore after this occurs and could potentially be injured. Now looking into Sally's medication, I found that Dilantin can cause painless overgrowth of the gingiva, which can create obstructive and biofilm retentive pseudopockets that make home care difficult. This hyperplasia will be worse if the patient has any pre-existing gingival inflammation, and the only way to attempt to resolve the issue is by discontinuing the offending medication and possibly with a gingivectomy. Sally's physical status consists of good overall health and vitals that are within normal limits. She does have occasional blurred vision when experiencing a visual aura prior to a seizure, and she also has occasional coordination issues. These slight coordination issues are a common finding in patients with epilepsy due to their condition involving so many parts of the brain. These are infrequent and do not limit her ability to complete everyday activities. Sally's mental status is impacted by her condition. As previously stated, generalized seizures consist of abnormal electrical activity all over the brain, so that could explain why Sally is dealing with symptoms like lethargy, drowsiness, and depression. These symptoms could also be side effects of her medication as well. Generalized tonic-clonic seizures do increase the risk for depression and decreased motor coordination. Although Sally does have these effects, she is alert and fully able to comprehend oral hygiene instruction, and her impaired motor skills are in no way inhibitory. Before looking intraorally, Sally's irritated and enlarged gums are suspected to be from her medication. She is also a teenager, so she may have some pubertal gingivitis that is exacerbating the overgrowth. With this medication, we know that gingival hyperplasia occurs in half of the users about 1 to 3 months after starting the medication. Sally has been on this medication for 3 months, so this is also a reason that we can suspect this being the cause. We can also suspect that Sally's hyperplasia, depression, and slurred speech could potentially be caused by this medication, as those are a few of the side effects, and we can see that it has many interactions with hormonal agents like birth control, anticoagulants like warfarin, and several antibiotics, one being clindamycin. Typically, prior to starting the medication, a patient would come in for weekly dental hygiene cleanings and oral hygiene instructions on how to prevent gingival hyperplasia as a side effect. Preventing this is much easier than treating it. While performing the extraoral and intraoral examinations, my findings were blurry and watery eyes, which is a symptom of her condition, bilateral crepitation of the TMJ with popping on the left. I spotted a 1 by 1 millimeter red petechia on the right side of her lower lip from a bite. She had gingival hyperplasia on the maxilla and mandible. There's bilateral linea alba and bilateral 1 by 1 petechia from a bite. There's a slight coating on the dorsal of the tongue. As we can see in this image, there is a 3 by 5 millimeter scar on the left side of her tongue from biting on it for the duration of her most recent seizure. She has very slight mandibular tori and her tonsils are present. She has class 1 occlusion with a normal overbite and a 1 millimeter deviation to the left. She experiences bruxism in her seizures and at night. She has adequate salivary flow and does tongue thrust while swallowing. All other findings were within normal limits. Now looking at the gingival inspection, both the maxillary and mandibular papilla are deep red in color, bulbous, firm, fibrous, and nodular in consistency. The gingiva bleeds easily and has hyperplasia. As for the maxillary and mandibular gingival margins, they are deep red in color with generalized bulbousness and firm, fibrous, and nodular consistency that has overgrown onto the tooth's crown. The margins show signs of bleeding and hyperplasia. For Sally's dental chart, I noted that all third molars are missing. There was localized wear facets and attrition from the bruxism during her seizure. There is a watch on the mesial of 14 and a class 4 chip on the mesio-incisal angle of tooth number 8 from her last episode as well. Sally does not have a removable appliance, but we can see on the chart here she has a lingual retainer from tooth numbers 22 to 27. Sally also has pre-existing sealants on tooth numbers 18, 19, 30, and 31. Moving on to the periodontal evaluation and radiographs, there was no indication of bone loss, but Sally did have probing depths of generalized 4 and 5 millimeter pseudopocketing and inflammation with bleeding on probing. This led to the official diagnosis of gingival hyperplasia and gingivitis by the dentist. Sally had no furcation involvement, mobility, or open contacts. Since her last x-rays were 1 year ago today, she has had a lot of changes since then. We took a periapical of number 8, 4 bite wings, and a panoramic. Looking at Sally's radiographic examination, we can see adequate bone level just below the CEJ. We can see her lingual retainer from teeth numbers 22 to 27, the watch on number 14, and the chip on number 8. She has no visible wisdom tooth development just yet. While completing a dietary analysis, I learned that Sally's family provides her everyday meals. Sally enjoys snacking throughout the day and drinking soda 1 to 2 times a day as well. Her favorite foods are smoothies, bagels, tacos, and spaghetti, which are all carbohydrates. I recommended the ketogenic diet to her and her father as there is some new research suggesting that it can be beneficial for this condition. When completing Sally's periodontal risk assessment, it was determined that she is at high risk for periodontal disease due to her gingival overgrowth being an obstructive and plaque retentive factor, and due to the side effects of her medication, her mental status, and more. Sally was also considered high risk for caries due to her special healthcare needs, xerostomia as a side effect, and her lingual retainer. Reviewing her overall oral hygiene status up to this point, it has been determined that Sally has generalized stage 2 gingival hyperplasia involving both the gingival margin and the papilla on both the maxilla and the mandible, along with generalized bleeding. Sally also has moderate biofilm and bruxism at nighttime. Sally's PHP score was a 2.0, which is fair, and due to her biofilm-induced gingivitis, moderate rate of progression, and moderate plaque buildup, I classified her as a 0 asterisk. When going over OHI and home care, we discussed Sally's diet and how snacking on carbohydrates and sipping on soda all day can cause cavities. Based on the comprehensive periodontal evaluation, today's treatment will consist of an adult prophylaxis and fluoride varnish. We will schedule an appointment for her to get a filling on number 8 to fix her chip, and we will schedule her at 4-month recare visits due to the anatomical barrier created by her hyperplasia. Sally generally has adequate motor skills and coordination. After experiencing a seizure, she may feel sore, fatigued, and depressed. Feeling this way can cause her to not brush and floss and could have a temporary impact on her fine motor skills. An electric toothbrush could be beneficial in alleviating any temporary impairments she may have and make brushing easier for her. Sally finds floss picks easier to use and is able to use a floss threader to floss under her lingual retainer. If Sally ever needs assistance with this task, her father will be able to help her. It was apparent that both Sally and her father understand the importance of meticulous oral hygiene. Here we can see a complete and detailed summary of today's appointment and Sally's treatment plan. I will continue to collaborate with her neurologist as treatment continues. Sally's demonstrated great comprehension and cooperation as with her father. I allowed Sally to practice proper brushing and flossing technique on my mouth model, and I tailored the OHI to her specific needs and motor skills. Here are my references.